Thank you, ma'am. Thank you, Dr. Lata and Dr. Raghunandanan for chairing this session. Now we'll move on to the next session, keynote address by the key person in medical education, Dr. Tejinder Singh. He'll be addressing on assessment of clinical competencies, challenges and strategies. I would like to invite the chairpersons for this session, Professor P.F. Kotur, Provost AVMC, and Professor Sitesh Ghosh, Dean, MGMC and RI, Puducherry.
Good afternoon, everybody. And with the permission of the speakers, I think already he has been introduced a lot. We'll not waste time in introducing him. Rather, we'll utilize that time for the question answer session or for his explanation. Is that okay, sir? Thank you. Thank you, sir.
Thank you, sir. Good morning, ladies and gentlemen. It's a pleasure for me to speak today to you on assessment of clinical competence, challenges and strategies. We know that in 2019 we introduced the competency-based curriculum with the intent to produce an Indian medical graduate with the roles of clinician, leader, communicator, lifelong learning and professional. And I believe 2 more roles have now been added to the roles of Indian medical graduate. So the entire focus or entire approach actually revolved on the clinical competence. Now, if we look at clinical competence, then it's a multi-layered concept. It's not very simple and straightforward to define, conceptualize or understand. And the perspective with which you are viewing clinical competence actually makes a lot of difference about what you make of clinical competence. At the same time, what I noticed over last many years interacting with various faculty in the country and so on, is that there is a lot of semantic problem between ability, skill and competency. And at the same time, the role of knowledge, I don't know how far it is correct, but I was told once that some high ministry officials felt that doctors don't even have the skills of writing prescription, and that's what precipitated the change in curriculum. So the entire focus actually came on skills, and in this skill, the role of knowledge actually become very shaky. Should we or should we not? And not to forget the challenge that although we talk of competency-based curricula, we still have to deal with the fixed time and subject boundaries contrasted to variable time and fixed outcome, which is the hallmark of competency-based medical education. What were the prerequisites to actually start such a curriculum? In 1976, Harris and Keller very appropriately suggested that the effort in competency-based education should not lie in the design of instructional material, but in the design of appropriate assessments. And I was so happy hearing the Honorable Vice Chancellor talk this morning about the importance of assessment in competency-based curricula. Unfortunately, our whole effort seems to be based on creating timetables and this and that, but hardly anybody talks about assessment. Now, I wonder if without an appropriate assessment, will we be ever able to achieve our goal of having a good competency-based education? At the same time, I am also reminded of what Jeff Norman said some 20 years ago, that those unaware of the past are doomed to repeat it. Are we making the same mistake which many people made in 2005 and we want to re-experiment it? Or we can learn from their experiences and actually move on to something different. So one of the best ways to me is to look at the evolution of assessment. Because the way assessment evolved was a reflection of our changing understanding of clinical competence. You cannot have a competence conceptualized one way, and you cannot have an assessment conceptualized another way. So the earliest phase in assessment could be what can be called measurement era. And this started somewhere from 1901 till about 1970s or 80s. Now, the hallmark of this phase was that competence is generic, fixed, and transferable. And mind the words, generic, fixed, and transferable. So you were born fair or you were born competent was one and the same thing. It didn't make a difference. But that was not the case. However, it still influenced our view of assessment for a very long time, almost 3/4 of a century. We kept on believing that competence is generic, fixed, and transferable across content. So if you could drive a Maruti, you could also fly a plane, and if you could fly a plane, you could drive a motorcycle, and that's the kind of conceptualization we had. And during measurement era, the key focus was that anything which exists in some quantity, and if it exists in some quantity, then you can measure it. Now, Sanjeev is going to talk about this tomorrow, so I'll not elaborate too much on this. But then came McNamara fallacy. And what it said, if something cannot be measured, then either it is not important or it doesn't exist. So we could not measure professionalism. It became unimportant. We couldn't measure empathy. It became unimportant. Even the best of institutions in this country do not have a plan to assess professionalism, communication, ethics, and the roles that we keep on adding to the Indian medical graduate. Come to think of it, how many of those can be measured actually? We have said critical thinker. How will you measure that? We have said researcher. We have said lifelong learner. So if we can't measure, they are not important. And if you don't assess them, then for the student, they are useless because they don't contribute anything to his or her career progression. And so the predominant beliefs during this phase actually, as I said, about competence. Second, that content, context, and situation plays no role. So what is the basic approach? That an assessment is an assessment. Whether you use it for class test, or you use it for a university examination, or use it for selection, what difference does it make? Test is a test. But that probably was not true. And the purpose of assessment was to quantify learning and to separate competent from incompetent. Even today, when we do item analysis of a MCQ, we talk of a discrimination index. We want to discriminate between students who know and students who don't know. Because that was the purpose of assessment. And the reliability assumptions during this phase actually were that objectivity equals reliability. Or in other words, if there is no objectivity, there is no reliability. And reliability was also seen as reproducibility. That was what was important. I give 5 marks, you give 5 marks, he gives 5 marks. Reliable. Nothing more than that. And then came a phase when we started manipulating numbers, item response theory. You remove items which don't contribute. It's just like saying that if doctor had not given this drug, patient would have survived. So let's tear this prescription from the case file and then see again if the patient could survive. But it was not all that bad, come to think of it. During this phase, there was advent of multiple choice questions, OSCEs, Osler, patient management problems, and so on. And to a certain extent, when you have to have a selection examination, when you have to deal with 2 lakh students for about, say, 5,000 seats, then these are the things you need to depend on. So it's not that everything in that era was bad, but somehow it all got overhyped and it actually sidelined the real purpose of assessment in competency-based curricula. Let's move to phase 2. The phase 2 was the decision-making era. And in this era, what we believe that competence is specific. So driving a car is different from driving a aeroplane, or making a chapati is different from making a dosa. And it is not transferable. It's not that if you can make a good dokla, you can also make good puri. That doesn't happen. So competence is specific and non-transferable. So in this competence era, if we look at the definition of competence, there are various, as I said, it's a multi-layered concept, and depending on what you want to see, you will have a definition. In fact, there is a review on definitions of competence in academic medicine, and some 50 or 60 definitions have been found out. But this one given by Epstein and Hundert is one which is most quoted and most often used. So we will follow this particular definition. And in this one, if you look at the keywords, although I have colored many, but the two most important things which stand out, one, that it is a integration of knowledge, skills, attitudes, communication, reflection and behavior. One. Second, it is something which has to happen in daily practice. So demonstrating it once in the practical examination or demonstrating it once in a OSCE will not make a student competent. And third, that it is something which is used for the benefit of the individual and community being served. We'll come to this part a bit later. And what were the predominant beliefs during this phase, which started from around 1980s and went on till about 2000s or maybe 2005. So from independent generic trait, we started talking of a combination of competencies. And this combination of competencies is what was called competence. And from one best tool, so earlier we had for theory, MCQ, for practical, OSCE, for this, that. Now we work on a combination of tools. And that combination of tool is called a toolbox for assessment methods. And why this is important is that each tool has indications, side effects, contraindications, and more importantly, no tool actually crosses a level of Merrill's pyramid. So a tool for knows will not assess knows how, and knows how will not assess shows, and shows will not assess does. So that is the reason why you have to go for a multiple combination of tools under the broad spectrum of assessment toolbox. Now during this phase, a lot of new things appeared. So mini CX, DOPS, PMAX, multi-source feedback, mini peer assessment, and so many others. I have just listed a few, but if you search the literature, you can find many more. If you look at this list, what you find is that compared to the earlier list of OSCE and MCQ and so on, these tools are subjective. These tools are unstandardized. And let me clear it at this point that subjectivity does not mean bias. Very often we tend to take it that subjective means bias. Subjectivity does not mean bias. Subjective means your own personal view or opinion. When a patient goes to two different doctors and they make two different diagnoses, it does not mean that they are subjective or one is wrong, other is right. It is their personal opinion. And the next phase after this was the phase of programmatic era. And during this era, the belief changed to that competence is not only specific and non-transferable, but competence is dynamic, incremental, and contextual. Dynamic, incremental, and contextual. And these things had a lot of influence on the way we actually would assess competence. Now, in the programmatic era, there is a belief, rightly so, that education, competence, and assessment, they are complex entities. And a comprehensive and holistic assessment is possible only through a program of assessment, not as individual add-ons. Critical reasoning, critical thinking, decision making, they may all have different ways of thinking. Everybody would think in a different way. But they are all acceptable. And during this phase, there was advent of, and these are important issues for us, assessment proportional to stakes. So for a class test, for example, your assessment does not have to be the same as it has to be for a selection test. In fact, you keep on accumulating evidence. You don't make summative decisions on a single test. And during this phase, actually there was a dissolution between formative and summative assessment. So you no longer talk about formative and summative. Why cannot the same assessment serve both purposes? It is formative till you come to the final point, and once you have accumulated sufficient number of formative assessment, you make a summative decision based on that. And you have to select the educational tool not on the basis of its reliability or objectivity, but on the basis of its educational justification. And a fallout of this argument is that you look at reliability of the program rather than looking at reliability of an individual tool. So what we know about competence is, and these are some of the important things which we tend to ignore when we are planning for teaching or assessment, that competence does not reside in the individual. It resides in the way an individual interacts with the context. So in other words, assessment of competence in one context is inadequate. Take for example a doctor. In a primary health center, he may be highly competent, but in a district hospital, he may not be so, and vice versa. Somebody from All India Institute may be highly competent in giving extracorporeal membrane oxygenation, but in a primary health center, probably no. So how an individual interacts with the context actually decides whether he is competent or not competent. And competence can be inferred only from performance. You know, it's not like you see somebody walking on the road, say, oh, competent, oh, no, incompetent. No, you have to look at the performance. This is what we know about competence. What we believe is that medical roles can be broken down into individual elements of knowledge, skill, attitudes, which can be rejoined to create a competency. Now, this strikes at the very root of advent of competency-based education. Why had the competency-based education come? Because the graduates were not able to integrate knowledge, skills, and attitudes when dealing with a patient. They could tell you 20 causes of pain and abdomen, but they were not able to help the patient who presented with pain and abdomen. And if we still continue assessing these elements individually, then we are probably making the same mistake over and over again. And second, that performance can be tested only like a race. That means precise to 0.001 second. You cannot test it like a gymnastic. That means we undermined the role of expert subjective judgment in assessment of clinical competence. And as I said, there was a semantic issue between skill and competency. Many of us believed that skill and competency are synonymous. In fact, I had one meeting with one of the vice chancellors, I won't name the university. So he told me, yeah, Tejinder, we have done that. We have made a logbook where we record all injection giving, this, that, blah, blah, blah. Because for him, all competencies were skills. If you have skilled, you have competencies. Let's look at the difference. A skill is a specific learned proficiency for performing a task. Specific learned proficiency for performing a task. Take for example, inserting a nasogastric tube in a mannequin is a skill. Competency, on the other hand, is a combination of knowledge, skills, attitude, and behavior that contributes to individual performance, leading to positive outcomes. And as an example, when you are inserting nasogastric tube in a child brought to the emergency with suspected poisoning, you are demonstrating competence. And this is the difference which is crucial. If you keep on assessing the student only on a mannequin, you are only assessing a skill. But if you assess a student in the emergency department trying to pass a nasogastric tube on a patient who has been brought there, you are assessing competence. And a fallout of this is that skills can be objectively assessed, but unfortunately competencies cannot be. By their very nature, competencies cannot be assessed objectively, because as I told you in the definition, competency is a combination of knowledge, skills, professionalism, ethics, behavior, reflection, so many things. Some of them may be assessed objectively, some of them may not be. And content specificity is in fact another important thing which I have been giving you multiple examples, that doing one doesn't mean doing other. So every competency has to be assessed at some level. I'm not saying you assess everything at the final university examination or everything during internal assessment. No. Some can be done during formative stage, some can be done during internal assessment, some can be done during summative, depending on their importance and feasibility and so many other things. We just heard Professor Banji talking about that CARV criteria. So feasibility, educational impact, so many things come. But content specificity has to come kept in mind. Assessing one competency does not mean that the student is competent in another. Now, another issue which actually came is that knowledge was kept at the bottom of hierarchy. I don't think this was intentional, it just happened like that. But somehow it conveyed to us that knowledge is the lowest level of learning. And there were suggestions to make the students to climb on top of the pyramid. You know, in some of my own earlier presentations, I have said that the more you climb higher, the more you attain validity. But it doesn't happen probably that way. And so the difference or the role of knowledge in performance becomes important. Now, whether you give 40% to knowledge and 60% to practical, you know, those are kind of tricky questions which one has to actually face and address. Those who advocate performance assessment at the cost of knowledge, and there are literature evidences to say that if you use performance-based assessment, they will promote learning of clinical skills. Fair enough. But there is also evidence to say that the students will resort to selective learning. So they might learn skills, but they'll forget about knowledge. And making a diagnosis is actually the first step in a doctor-patient interaction. If your diagnosis is wrong, no amount of skills or communication or professionalism is going to help the patient. Your diagnosis has to be correct, and a correct diagnosis depends on a sound knowledge base. And then came another realization that experts are experts because they know more. Experts are not because they can perform something extraordinary or because they have some extra skills. No, experts are experts because they know more. So the importance of knowledge cannot be really undermined at any stage. And when I say importance of knowledge, we have been actually emphasizing over this for last many years. I don't mean a knowledge of discuss and describe variety. I mean a knowledge to make a clinical diagnosis, a clinical reasoning process, to overcome diagnostic errors, and so on. And what do we know about the shows level? That's also interesting. Validity depends on the fidelity of the simulation. How close it is to the actual task that the student is going to perform. And if we view from that point, many OSCEs actually keep on testing skills in isolation. Many of you must have heard about Ara Tekian from UIC Chicago, and once he told me that he has seen multiple OSCEs across the world, and according to him, most of the OSCEs are actually artifacts. They are not testing what they should be. They are testing something else. The second important lesson that we learned about shows is that global ratings do as well. In fact, they provide better discrimination between students who know and who don't know, and they provide a better inter-case reliability. The marks might be different between two examiners. The ratings might be different between two examiners, but between two cases, and that is what is more important than actually simply having a reproducibility of the marks. And OSCE impacts learning. Multiple studies from Maastricht to show that students actually memorize OSCE checklists rather than learning the procedure. And from personal experience of having conducted OSCE at CMC Ludhiana from 1992 onwards, almost 25 to 30 years, I can tell you, you can never keep your checklist safe. Invariably, maximum you can do is 2 iterations, 3 iterations, 4th time you know the student has already had access to checklist and he has memorized all that. And what are the key lessons regarding does that we have learned? That if you have 8 to 10 samples or encounters in a year, then you can get sufficient amount of reliability for making even summative decisions. And again, like shows, the qualitative and narrative information is actually more useful even for does part of it. And so the authentic assessments, the theme of this conference, I'm so happy that they have actually, I was particularly, what caught my attention was to say that we have to move beyond assessing objectives to assessing competencies. And again, what actually inhibits us from going into this area is that most important things are the most difficult to measure. It's very easy to measure knowledge, recall type of knowledge. It's very difficult to measure professionalism. And so you have to make a choice whether you want to go for standardized test or you want to go for authentic measures of doctoring. There are a whole lot of things that you as a practitioner do with the patient which do not come in the formal assessment plan, but which make a lot of difference in deciding whether you are able to help the patient or you are not able to help the patient. Validity, I already told you, fidelity is important. And we actually, in basic workshop, most of you must have heard that there can be no validity without reliability. But in fact, that's not the case. In fact, there is a seesaw relationship between validity and reliability. If you try to make it reliable. And when I say reliable, I'm only talking of reproducible. I'm not talking of reliable in the other sense, reproducible. So if you try to make it reproducible, then what you do, you'll try to cut off as many contexts as possible. And the moment you start cutting off context, you are bringing down validity. Reliability is another issue altogether. This has been one of my favorite tables, and maybe some of you have seen it earlier. What actually attracts attention here is that a long case has higher reliability as compared to OSCE for 1 hour. But as you keep on increasing the testing time, the reliability keeps on increasing. So in other words, it is not the objectivity which actually decides reliability. It is the sample size which decides. And when I say assess all competencies, assess them during formative, the reason is here. You have to increase the sample size of what you are going to assess. And not only increasing the sample size increases, in fact, if you aggregate or club various assessments together, then you are again benefited. Look at this, sample size for standalone multi-source feedback is 9. But if you club it with other assessments, you need only 2. So have multiple assessments, have assessments in combination in the form of an assessment toolbox, and that is what is going to help you out. We hear this phrase very often, assessment drives learning. Does it? Yes, it does. But unfortunately, the impact of assessment on learning is often negative. And what is that negativity? It promotes poor learning style, encourages grade culture, and purge and binge mindset. Just read 3 days before the examination, go and vomit there, and then forget about everything. You don't need to remember it. And reductionism. OSCE, you are just cutting it down to toolboxes, checklists. There are very few longitudinal elements in the assessment process. For doctors, in fact, it is very easy to understand student assessment because there are a lot of similarities between healthcare and student assessment. Let's see those. When you encounter a patient, you take history, perform physical examination, then you have scripts, gut feelings, intuitive diagnosis making, investigations only to confirm or refute your diagnosis. You don't do investigations to make a diagnosis. Then you treat, and then you follow up to see the progress. Same happens with the student. Certain narratives, certain subjective, certain investigations, giving time to the student to make up and understand. Have an exam today and repeat a test after 2 weeks doesn't make sense. No one of us tells a patient who comes with a hemoglobin of 8, okay, get it done again tomorrow, might improve. That doesn't happen. You have to start mechanics, give some time for the body to respond, then see if it is responding or not. Same thing happens with student assessment. And equally important is the concept of meaningful aggregation. No physician would tell his patient that your blood sugar is very high, but fortunately your serum sodium is very low, so on an average, you are all right. But we do the same for students. There might be a resuscitation station and we'll say, pardon me for saying this in Hindi because I can't translate it in English, कि बेटा you could not save the patient, पर तूने death बड़ी अच्छी declare करी थी, इसलिए तू pass. So what we do, all OSCEs we combine, irrespective of whether they are from what system, what competency, doesn't matter. OSCE, lab, practical, so combine all practicals. MCQs, theory, combine all theory. We don't do that for clinical medicine. You don't multiply RBC count by WBC count, divide by platelet count to the power of serum amylase. We don't do that because they are all laboratory tests. You view each one of them individually. Same way, each assessment gives you individualized information for the student. And rather than aggregating them like this, in fact, a better option might be to aggregate them system-wise. Knowledge, practical skills, communication of the same system to be added. To me, having a standalone station for communication is one of the worst things one can do to assess communication. Because communication to a patient to modify his lifestyle will be very different from communication to a just delivered mother to adopt a family planning method. You cannot say that he can do one, so he can do also the other. And what is the role of assessor? In fact, that is becoming more and more important in the recent times. And there are multiple reports to suggest that assessment expertise and assessment literacy are two very important things. And as said in the morning, this era of ACME, BCME probably is gone. You have to now focus on specialized assessment training, performance assessment, setting good quality MCQs. I have reviewed some papers from some journals where people had the project of effect of faculty training on MCQs, quality of MCQs, and unfortunately none of them demonstrated that the 2-day program or 3-day program actually resulted in better MCQs. It's a long drawn process, it takes time. And to the extent that Lockyer et al., when they wrote a paper on behalf of international CBME collaborators, they said that in competency-based education, it is the assessor which becomes the primary instrument rather than the tool that he or she uses. And it's interesting to really go back to the Gurukul system. What used to happen during Gurukul system? There was no NEET, no NEXT, no computer-based learning management system, etc., etc. Rather, it was simple things. Ongoing, low stakes, mentoring, multiple context. Of course, the pupils had to go out and demonstrate their competence once in a while, when marrying some princess or something. Then they would go and demonstrate. But otherwise, it was the guru who decided whether the student is competent to move out or not. And so, what implications it can have for the assessment we have? First, that cognitive elements need more emphasis in assessment. And as I said, cognitive, just don't go for discuss and describe. Cognitive means diagnostic reasoning, clinical reasoning, how to make a diagnosis. That is what becomes important. Knows and knows how probably get enough attention during basic years. First, second year, they still get importance. But during third and fourth, the entire focus shifts on to performance assessment. So that is where you need to actually bring up and continue using knows and knows how during clinical years as well. And you have to assess at all levels with integration of domains. In fact, what Professor Van Luton has suggested is that rather than viewing the Miller's pyramid like this, you invert the pyramid so that you'd have assessment from each layer to give you a better and a complete picture of the clinical competence. So where does this lead us to? Last year we had given a conceptual map of competency-based assessment based on what is already known. Of course, it has to be criterion referenced. You can't compare one student with the other. It should be continuous, workplace-based, using expert subjective judgments. But what is more important is it requires a lot of mentoring and lot of feedback. These are two key elements which will decide the success or failure of competency-based assessment. So what's the carry home? I leave you with certain points. I've already elaborated them during my talk. Next time when you plan your assessments, keep these things in mind. And remember, investing in assessor training is worth it. Before I conclude, however, I'll like to take you to the story of Krishna and Arjun. Arjun had the knowledge, all the knowledge about all the weapons. He had the skills. But when it came to demonstrating his competence, he backed out. And it required a Krishna to diagnose and address that problem. He didn't tell him, okay, you don't want to fight? Fine, go for a fellowship, come back, then we'll fight. He didn't do that. He addressed issues which could not have been measured by the conventional assessment. Conventionally, they would just ask him to shoot an arrow to hit the bird's eye and he would pass. But those were not the issues which were preventing him from demonstrating his competence. And interesting that the discourse, which must have went on for at least 3.5 hours, 700 shlokas spanning over 18 adhyayas, there is not even once a mention of war. A discourse prompting Arjun to go for war, not even once mentioning war. I suppose as medical teachers, we are preparing the future Arjuns to go and fight the battle with disease, socioeconomic situations, epidemiological problems, and so on. And we have to ensure that these Arjuns do not give up when they need to demonstrate their competence most. Thank you so much for your attention.
Thank you, Professor T.S., for taking us a wonderful journey of various era in the assessment, evolution of era. And what is this? Yeah, one question has come before that. You told us 3 phases, fine. This is, and you halfway through your lecture also you mentioned, this is an evidence-based era and evidence-based assessment as well, as a basis for evidence-based education. When we don't have enough evidences as to what method we choose for assessment, etc., where do we stand? Because as such, you said assessment of competence is a complex issue.
Sir, we have enough evidence. And that's what I said right in the beginning, that do we want to learn from others' mistakes, or do we want to make our own mistakes? There's plenty of evidence. Indian evidence is not there, of course, but globally there is enough evidence about assessment.
Doctors who are not making evidence-based assessment of the patients in clinical decision making, some of the, of course, American statistics says 400,000 errors per year. That kind of literature we read.
So if we look at assessment errors in India, probably the number would be even much higher.
Yes.
Because unfortunately, in our country, we do not have any research on assessment. You know, we do not know whether after having All India pre-PG entrance examination, were we getting better graduates? We don't know. After NEET, have we started getting better graduates? We don't know. After next, we'll start better graduates? We don't know. We just keep on working on the assumption that it's okay. I mean, if we like it, then probably it's
That's a fact. Yeah. We have one question, only one question, that time is up, from the audience, from Dr. Nayyar Iqbal. Although we have CBME curriculum, but still importance is be given for assessment of learning rather than learning.
For assessment. For assessment.
Learning, because more importance
Is
is given for summative assessment. I don't know, you interpret the question. Who is, yeah,
Please. Yeah, let's hear from the person concerned.
We are still in the era of the first era or maybe the second era. The problem is even the CBME tells that you do competency-based assessment, competency, but the reality is we only want to test students at the last when they're passing out, and summative is more important at the time it comes, from the first year onwards. The problem, I don't know what is the problem. Where is the problem actually from your expert you can tell us where we are lacking as a facilitator, that how we can go forward and start making student assessment in a more programmatic way, or as you are suggesting.
You know, there are multiple factors, and I don't think it is the right forum for me to actually discuss all those. But the major issue is that we do not want to disturb the status quo for assessment. We adopted a new curriculum, but we kept the assessment the same as used to happen for the previous version. Now, obviously, a new curriculum cannot be assessed by a new older assessment model, and one has to change. And I don't know, or I don't think that we have enough of willpower to really, you know, stand up against that and say, ki, no, if curriculum is changing, the assessment has to change. We still keep on assessing isolated learning objectives. We are not even assessing competencies. Forget about summative and formative.
We have two questions, but I'll take one question only because that matches with my thought process. How to take cases, how to take care when the students simply mug up the checklist?
Yeah, again, see, another thing is that assessment is not non-contextual. So, if the student knows that his or her future career depends on one MCQ test of 3 hours duration, then obviously his orientation to the whole thing is also different. You know, you tell me, if you and I are in that position where your career is going to be decided by one MCQ test, will we read MCQs, or will we go to learn the skills and professionalism and communication and so on? Probably not. So we have to look at the whole thing. Now that I think we are discussing next in the next session, so many of these things actually would come over there. So let's keep it for that.
I know like lot of questions are cropping up in the minds, but we have to respect to the time and the next speaker also. And yeah, I think that this questions, yeah, you can have the questions to the sir, and you will get the answer for that one. I know, like sir can talk hours on assessment.
Lunchtime, they can.
Yeah, lunchtime also you can interact. Can we have a standing ovation for sir? Any medical education journal, nowadays sir name is not coming as a Tejinder Singh, it is coming as a TS. Now he has become so familiar with that one. Thank you, sir.
Thank you, sir, for this excellent session. I request the chairpersons of this scientific session, Professor P.F. Kotur and Professor Sitesh Ghosh, to present the memento to the resource person, Dr. Tejinder Singh. Thank you, sirs. I request Dr. Sheng Po Kha, Director, Center for Humanities in Medicine, Taiwan, to present the mementos to our chairpersons, Professor P.F. Kotur and Professor Sitesh Ghosh. Thank you, Dr. Sheng Pokor.